drugs for diseases of the lower respiratory tract, bronchodilators, and other respiratory drugs. Bronchial asthma is the recurrent and reversible shortness of breath. It occurs when the airways of the lungs become narrow as a result of bronchospasms, inflammation of the bronchial mucosa, edema of the bronchial mucosa, and production of viscid mucus. With bronchial asthma, the alveolar ducts or alveoli remain open, but airflow to them is obstructed, so we see wheezing and difficulty breathing. Sometimes asthma is caused by allergies, and sometimes we just don't know why it's caused. Status asthmaticus is a prolonged asthma attack that does not respond to typical drug therapy. It can last several minutes or several hours, and it is an absolute medical emergency. So what drugs do we use? We use bronchodilators, and there's two classes of them, the beta-adrenergic agonists and the xanthine derivatives. We use anticholinergics, anti-leukotrienes, and corticosteroids. Bronchodilators, beta agonists. This is a large group, and they are the sympathomimetics. They're used during the acute phase of the asthma attack, and they quickly reduce airway constriction and restore normal airflow. They stimulate the beta-2 adrenergic receptors throughout the lungs. Okay, there's three types of beta agonists. Non-selective adrenergics, they stimulate the alpha, the beta-1, and the beta-2 receptors, and an example here is epinephrine. We have the non-selective beta adrenergics, which stimulate both the beta-1 and beta-2 receptors, and example is metoprolol. And the third type just stimulates the beta-2 selectively, and that is albuterol. We use these drugs to relieve bronchospasm related to asthma, bronchitis, and other pulmonary diseases. It's useful in treatment of acute attacks as well as preventing them. These drugs are used in hypotension and shock, and some of them are also used to produce uterine relaxation and prevent preterm labor in the pregnant woman. That's got nothing to do with the respiration. Adverse effects. Well, the alpha and beta drug, epinephrine, we see insomnia, restlessness, anorexia, a vascular headache, hyperglycemia, tremor, cardiac stimulation. As opposed to albuterol, where we've just got three, we have hypotension or hypertension, a vascular headache, and tremor. So albuterol is more commonly used. There are less adverse effects than epinephrine, but in an emergency, you want the epinephrine. For nursing implications, please see your text. Alright, the xanthine derivatives. Again, these are bronchodilators, and in this group is theophylline and aminophylline, as well as other drugs. They cause bronchodilation by relaxing the smooth muscles of the airways. So we get relief of bronchospasm and greater airflow into and out of the lungs. They also cause cardiovascular stimulation. So we see an increased force of contraction and an increased heart rate, resulting in increased cardiac output and increased blood flow to the kidneys, which is a diuretic effect. We use these drugs to dilate the airways in different types of asthma, bronchitis, and emphysema. Adverse effects: nausea, vomiting, anorexia, GI reflux during sleep, that's life-threatening, sinus tachycardia, extrasystole, palpitations, ventricular dysrhythmias, and transient urination. These are pretty serious adverse effects, so these are not your first-line drugs. Your xanthines are not your first-line drugs. Nursing implications, see your text. Alright, we move on to the anticholinergics. Acetylcholine causes bronchial constriction and narrowing of the airways. Anticholinergics bind to the acetylcholine receptors and prevent acetylcholine from binding. The result is bronchoconstriction is prevented and the airways dilate. In this group is Atrovent and Spiriva. They cause a slow and prolonged action, so they're used to prevent bronchoconstrictions. They are not used in acute asthma attacks. You know, they take a long time. They're slow and prolonged. They won't work fast enough in the instance of an asthma attack. Adverse effects: dry mouth or throat, nasal congestion, heart palpitations, GI distress, headache, coughing, anxiety, but there are no known drug interactions. Leukotrienes. That's a newer class of asthma medication. We have Singulair, Accolate, and Zyflo in this group. The result of all their anti-leukotriene action is we relieve the coughing, the wheezing, and the shortness of breath. But these drugs are used to prevent the problem. Inflammation in the lungs is blocked and asthma symptoms are relieved. These drugs are used for prophylaxis and in chronic treatment of asthma, and they are not appropriate to be used in acute asthma attacks. Nursing implications, see your text. Corticosteroids. These drugs are anti-inflammatories. They're used for chronic asthma, not to relieve the symptoms of acute asthma attacks. They can be given orally or in inhaled forms. The inhaled forms have less systemic effects, side effects, than the oral forms do. But these can take several weeks before full effects are seen. In this group are Beclovent, Vanseril, Asmacort, Decadron, Respihaler, Flovent, Flonase. There are others. There's a lot of steroid inhalers out there. We keep these drugs for treatment of bronchospastic disorders that are not controlled by conventional bronchodilators. These are not considered first-line drugs for acute asthma attacks or status asthmaticus. If we're using the inhaled versions, we see problems with pharyngeal irritation, coughing, dry mouth, oral fungal infections, and for other implications, I'm going to send you back to your text.